years. Over time, it won't, So I think it's definitely not losing sight of that. Um, but I think the excitement, though, that it brings is definitely really looking at healthcare is more than just what we always have thought health to be. Healthcare to some folks, depending on who you're dealing with, housing is healthcare. Depending on who you're dealing with, the access to education is healthcare. I think there are definitely lots and lots of conversation around, the social determinants of health, and people are just so excited. And and I think for me, I'm definitely of that generation where I'm just like, but the community have always said this all these years,
Define social determinants of health, would you?
So social determinants of health are the social factors that exist that affect a person's health outcomes. I think you spoke about not having insurance, but you're like, I'm not sick. But on the flip side of that, there's also preventative care. Are you doing the regular checkups? But for a lot of folks in our community, that is the reality, right? Because where do you go for preventative care if you're uninsured? So social determinants of health really looks at all these, like these downstream factors that affects a person. Oftentimes when we see an individual, I should use myself again as an example. So when you see me, you have these assumptions. I'm a woman, I'm black, whatever else you may have. But the things that you don't see and don't understand that affect me as an individual is that I survived a civil war, but I also have education, and having education is a protective factor. There's also lots of conversation that happens where people oftentimes always talk about, people just need to eat healthy, fast food, people just eat fast food. Like, well, have you ever talked to anybody who's on food stamp? If you're getting $130 a month and you have 30 days in the month, let's figure out that and what that looks like. Just even like when you talk about what's happening right now in Oregon, you look at all this the conversation around transportation equity, right? Where TriMet is looking to do the bus, the cuts because they need to save money. But for folks from the community that I work with, the community that I represent, what does that mean for that woman? And I give one of the mayor candidates a perfect example. I say, oftentimes when you're elected official talk, they talk in these big ways. I'm like, a common average person just needs the lowest common denominator. And a woman, I remember I was talking to her, she's like, for me, this is what it's gonna mean. Instead of me standing at the bus stop at 4:30 in the morning, I'm gonna have to be at the bus stop at 3:30 to make sure that I'm at work at 6, to make sure that I can provide for my 4 children. So really, social determinants of health is really looking at all these other factors. Looking at the environment, I think, we also talk a lot about obesity. It's access to food. But one thing that we don't talk about is the environment. How does the environment that children live in contribute to obesity? If you look at East County, there's all, and I always talk about this, the 122nd in Powell, and I'm just like, God, one day, God forbid, a child will die, and then all of a sudden we'll have this huge uproar that we need to build sidewalks. I mean, you'll see kids riding the sidewalks. They don't have anywhere to ride the bikes, but here they are on the sidewalk. And I think, unfortunately, we have a system that's set up where we're very reactive. We never want to really have that responsive approach. We wait for something traumatic to happen, and all of a sudden, like, let's pour the resources into that. But I think part of what this conversation with healthcare is forcing us to do is to really say, we're spending all this money, and compared to other parts of the world, we're really not getting that kind of health outcomes. But how do we stop, pause, and reevaluate what we're doing? How do we look at education as a protective factor? There's all this research that shows, a child who's born to a parent who's incarcerated, what does that mean for that child? But yet we live in a state in the region where we pour more money into building correction facility than we pour into higher ed. And if we continue to do so, what does that mean for, where we are heading? And I think part of, it's kind of getting ahead, thinking about like the call to action. Like, are we really asking these questions? Are we really looking to change this conversation? Like, what are the true policies that are really looking to address and really pretty much like take charge and really look to just reevaluate all the policy and different systems that we have in place? And I think that's part of what healthcare reform is doing. I really think that's what social determinants of health is going. I'll add one more thing, because it's like I might go on, but I think when you look at, and I think it makes, I definitely see the value and validity in doing research oftentimes. However, I also think we have over-researched everything. Like I'm like, if you're running for office, do not promise you would do another research. Promise us that you will dust off all the policy recommendations that have happened all these years and figure out how do you apply these call to action. Because we spent all this money. I remember when I started working at Kaiser, I was just like, oh my goodness, right at that time, the NIH had released this big study on the effectiveness of breastfeeding. And, they were like, toting and talking. I'm just like, I said, I just have one thing to add to this. And I said, my grandmother, who is, at the time she was 81, I said, she has a third grade education, and she's always known breastfeeding has always worked. What if instead of putting this $5 million into figuring out that breastfeeding is effective and figure out how do you help people breastfeed, like what could that really do for our system? And I think we really have to push, act, and advocate for those really more thoughtful ways on how it is we move forward. And I really think that's what healthcare reform is doing.
In a very, very broad way you're talking. Emily, you work at the Office of Health Authority in the Office of Equity. I'm not getting it right now, but so from where you sit, what are the challenges and hopes of the healthcare reform in Oregon for access?
Well, I actually have a lot of hopes, and I'm really excited about this health systems transformation effort, the CCOs, the Coordinated Care Organizations, and all, what my panelists have already mentioned. I mean, kind of integrating both physical and mental health together with dental too, like putting all of that together and being patient-centered. So having like a team of providers that are talking to each other about that patient, because in our current system, it's so fragmented and siloed. And in Native communities, for some of the seniors, they're taking on average like 9 medications a day, and prescriptions from different providers who don't speak to one another and don't understand the contraindications, and the mixing of all these medicines. And so there was actually this medicine project that decided to do a different model and kind of get all those providers serving the Native community together. And it was kind of like a coordinated care organization model, like a pre-CCO model. And it was so effective in reducing the number of medications and just creating better health for these Native seniors. And this actually happened in the state of Minnesota, where the Minnesota Department of Human Services then decided to implement that program, that approach for the whole population, the whole Medicare population in Minnesota. And so, so I'm really excited about like a holistic approach that's focused on the patient, the person, and also moving more upstream, so it's not just the person in a clinic setting, but it's a person in a broader community setting. So it is about, do you have the grocery stores that have fresh fruits and vegetables in your neighborhood? Or, it's more communication happening between providers and kind of the broader community where health really gets created. And so the other exciting thing I think about this new team approach is incorporating community health workers and doulas, as part of the team, and, certified qualified medical interpreters. And, community health workers, I mean, those folks can really help to bridge that chasm between the providers, and the patients, or the professionals and the clients, can really help to bridge that understanding, because often, the Native community, since at least the 1960s, have used community health workers, members of their community who understand their culture and understand, their health, the way that community defines health. Like having them as part of that team, to improve health. And same with, the Latino community. They've had promotores, for centuries. And so incorporating those folks into the team, I think, is going to be a positive thing.
I mean, I think, community health worker, I think it's a term that you hear now more, but it's been in existence for a long time. Like Africa, it's been
Say the term again?
Community health workers.
Community health
I mean,
workers,
they
right.
have different names, or it might be lay health workers. I think especially from the African culture, it's like, the older women who's a mother to 5 kids. Like, who best can help support a woman who's pregnant than a woman who's had 5 children. And I think it's a concept that's been there, but I guess we're just catching up with it.
I'm thinking even of my mom, who's 75 and goes down to visit her 83-year-old friend down the block and just make sure she gets out for a walk every day. Not an official community health worker, but somebody she can relate to and all those things. Liz and Ramin, on the changes expected in Oregon, what do you think about, what do you hope for, and what do you worry about?
I am hopeful that things will work better. I am very concerned for people with behavioral health problems. These would be the typical people I work with, people with mental illnesses that have had a lot of stigma all these years. And one of the questions I have had is, how are you going to treat their clinical records? Typically, there have been issues surrounding confidentiality with these records, so we don't know how that's going to work out 100% yet. I still hope it preserves that, but that people come to recognize that mental illness is something that could happen to anyone. And in fact, no matter what we talk about, no matter how integrated we want to be, it all has to start with the attitude of the people, their willingness to accept each other, their willingness to work together. So that, I think it needs further study.
And the doctors.
Limited.
Do you mean the doctors in particular? Do you mean the doctors, the providers in particular, who are going to have to work together?
Yeah, absolutely. We're just going to have to see how it works. I know it's working in some places like Texas. They're already in some places doing it, but right here, I'd want to see what happens and do a little follow-up, and then we could say, it's working. But there's always hope.
Ramin Mizari, what's going to change in the emergency room?
I don't know, I think is the honest answer.
You're not alone.
Yeah, I don't have that much more to add. This is the story of my life, being at the end of the alphabet here with my last name. But anything I think that gives more access to insurance or more coordination of care are obviously positive steps. I don't view this as being a panacea. I think it's another attempt to improve the system, and I'm hopeful as well. I guess what I would just say is I think that there are a lot of very, very good people. There are a lot of very good healthcare providers, physicians, and all through the healthcare system who want to do the right thing. And so it's just a challenge of tremendous proportions to try to figure out how to create the building blocks that are, and then all of the other elements that are outside of the healthcare system per se, as was mentioned before. So I have a lot of hope because I see a lot of people with good hearts and who want to do the right thing. So I'm hopeful that with each of these little building blocks, that they become instruments through which that spirit of goodwill can hopefully affect positive change.
What I feel like I've heard a lot tonight is a real mismatch of resources. I mean, you all have come up with places people can go and programs they can turn to, but yet there's still this gap. Patrick, you had mentioned this image of a relay race, and this is the time to go to Margaret's story, where the story of the construction worker who came to the emergency room.
Thank you for letting me have the opportunity. So I work for Providence, as Liz did. She's now retired, and our mission is, as people of Providence, we reveal God's love for all, especially the poor and vulnerable, through our compassionate service. And the way we look at it is we're all one heartbeat away from being one of the vulnerable. And we had a construction worker, 42 years old, who came in, had lost his job. He had been in construction, but with the economy had lost his job, and came in with a wound infection. And he had needed to be hospitalized, so because of the law, we screened him in the emergency room. He was hospitalized for about 2 weeks for what was called debridement, where they try to clean the wound. He had antibiotics, and then he was discharged to home. He had no insurance. He worked for a small construction company, so he didn't have the option of COBRA. It wasn't an offering for him, and he couldn't have afforded that. He had lost his home, and so he was stabilized and discharged, but without a really good discharge plan, and he started coming back to the emergency department, one of our frequent visitors in the emergency department. And Providence has a program that all of the physicians who are on staff are required to continue the care of a patient for that episode of care. It's called City Call, because any of the primary care clinics participate in this. And on one of his ED visits back, we recognized we hadn't been on City Call when he had come through before, and we were. And because of that, we follow up, and he was assigned to us through the City Call program, and was unassigned. He had no primary care physician. We were able to assign a care manager who could coordinate his care. We actually did a team conference and brought together a group of specialists from the wound clinic, from the IC, the immediate care clinics, from the emergency department. We have an initiative where we actually do shared treatment planning with the emergency department, and our case manager, and we also brought in financial, but most important, because this had been going on now for some time before he actually came to our door, we brought in behavioral health because he was progressively depressed. And we were able to put a plan together. He had twice-a-day dressing changes, what are called wet to dry, and they would take about 2 hours each time. He had been living on with his ex-wife, and what we learned was he'd been living on their sofa, so he really didn't have a good environment. Home services had gone out before, but they felt it wasn't a safe environment, so they didn't want to see him anymore. And so we were able to bring home services back, actually helped relocate him to a sister's home. She had her own medical issues, but we were able to have a shared plan with her so she could care for his dressing in the morning. We brought him into and assigned him to a primary care physician. Between the primary care physician and the IC, we would alternate for these daily changes until he progressed to the point where he could be seen once a day, and then it became just twice a week, and now he's healed enough that he's actually ready to go back to work. And in talking with him, one of the things for him, and I so appreciated Maria's comments and Liz's comments, was as we interviewed him through this process, he said he had felt so abandoned by the system that nobody really cared about him. And so our case manager was able to step in and help facilitate this care, but it really gave him his self-esteem back. And it gave him the sense that somebody really cared about him enough to get him back on his feet and to heal his wounds that were far more than the original wound infection. And so I think it's a wonderful, demonstration of all the pieces coming together. And because we're actively involved in the CCO formation and the patient-centered medical homes, this is what all that's about for us.
What also strikes me as I hear that story is the incredible amount of resources that is. I mean, how many people are out there who need that many resources?
An incredible amount. I think the current estimate is that with the changes with the Affordable Care Act, there'll be 32 million people that are currently at some level of likely uninsurance that will need health care. And we, as a healthcare community, are just not poised to care for the sheer volumes. I see a lot of head nodding. But I think coming together, we have greater opportunity than we are standing alone.
We're running up on 8 o'clock, and I want to invite this last few minutes before we switch to just what you can do to ask any questions, scenarios. Go back to Alexi if you want, or whatever you'd like to ask.
Well, I just wanted to comment, especially to you, Margaret. I've had 2 back-to-back medical emergencies. One as a totally uninsured, unemployed, lost everything, no money at all, person in another state, and having thank God, being taken to a Catholic hospital which took care of me. Then, not too many months later, I had another situation, and I am an AmeriCorps volunteer. I am covered by a really poor insurance plan, but it is something. So when I had my second medical emergency, I was taken to Providence, I ended up being one of those people that falls through the cracks because I have some form of insurance. Doesn't matter that it really doesn't cover very much. And 7 months after the incident, they still haven't paid a dime because it's all wrapped up into pre-existing. And many of the ways that Providence tried to help me, to get me continued care, to get me additional situations, I ended up with a lot of other compounding problems. I was blocked in every way because I had insurance. Despite the fact that it is possibly not going to pay a dime of this, so thank God again I went to Providence, but it was very disheartening. I'm also 58 years old, so I was in the limbo of I'm too old for some things, I'm too young for other things. I could go to this clinic, oh, you're only 58, oh, sorry, you gotta be 62. And it was like, oh, you need housing, or you need some mental health, oh gosh, too bad, you need to be this, or you need to be that. And so I found that, thank goodness I wasn't so sick that I couldn't get on the phone, and for about the first 2 months of my AmeriCorps assignment was pretty much, I was responsible for navigating a big healthcare mess, of which I'm still navigating because I have insurance. My concern about the coming insurance is whether or not that same loophole where you have just enough to make you not qualified for certain things is going to continue, because that's almost caused me more stress than had. In fact, I was actually told by former AmeriCorps, don't take the insurance. You're better off without it if you get sick.
If I could just say, I'm sorry for your experience, and certainly people fall through the cracks, and that's part of what we're trying to resolve. I can tell you, and you probably weren't aware of this, and that's a learning for us, is every one of our Providence clinics has a case manager that you could have requested who could have helped you navigate the system. So I'm sorry I didn't know about you, because we could have helped facilitate that for you. But it's a great demonstration of the fact, as was said earlier, sometimes there's services and resources out there that people just don't know about. So we have to do a better job as the providers to make sure people are aware of that. So.
Thank you, everybody. I'm wondering if you could respond for us your feelings about the proposed national health plan. Thank you.
Do you mean, just so I can understand it, do you mean single payer, or do you mean the insurance mandate?
The insurance mandate.
The insurance mandate.
The insurance mandate.
Well, let's start with the whys.
Oh, how nice.
Yay.
Well, I think I'm 100% in favor of national health care, or some form. I mean, what exact form that will take, and having coverage for everyone. So because I'm on the front lines of that, and because we have a national mandate for ERs to care for every person, but it's an unfunded mandate. So it makes for a very challenging business model in emergency departments, and so there is a special sweetness to caring for someone who has no ability to pay for it. So that's a very special part of my job, and I think of a lot of physicians and healthcare providers' jobs. But in terms of a sustainable system, there has to be fairness all around, and I think having coverage for everyone in a system that addresses that will ensure that then there are providers always for, to care for people. But there are many complexities to that too.
Liz, let's just ask everyone to weigh in briefly, because we still do want to get to how you can influence the system. Do you have any thoughts on the national mandate for health insurance?
I would like everyone to get help. Yeah. Sure.
Emily?
Similarly, yes. I think there's part of the reason they're taking that approach is to avoid kind of cherry picking. So like the more people that you have in the pool, you're not just picking the healthy people to be in your pool, but so that the costs are going to get shared no matter what. Like you'd heard earlier, if uninsured folks are going into the ER, they're going to get served, and then everybody's going to end up paying for it, at some point. It's like at different points. It's like this shell game, So I'm for, universal coverage, everyone having access to.
Julia?
I'm in favor. Like I always tell people, I say, we're required to have insurance for cars, boats, and everything else. And I think the most important asset you have is your body. And I think it allows us to do so.
Patrick?
Yeah, well, it's kind of an easy answer to say yes. But what's interesting about the question in answering it is the state of Massachusetts is basically there right now. It has almost full insurance. I believe it's 1% or 2%. And that has achieved some success in terms of access. It has not addressed the cost of healthcare. So there have been some successes that would hopefully then replicate further.
I'm going to be a little bit really hopeful here. I would like not only to have access and insurance for all, universal insurance, but I would like to see a big emphasis on living well and staying well, and people doing things that maintain their health and their well-being. So I look at it in a global and community way, that if somehow that insurance mandate can include things like the creative arts or things that make people well, spirituality is part of health. It's all connected. So I would say yes to the universal health care, but let's make it also inclusive to all areas of life, because that's where true wellness is.
Sheila, what a good question. So this is an interesting question, because I certainly want to support more individuals having access to health care that's not fragmented. And I'm hopeful that through the Affordable Care Act, that's some of what we'll see. However, my concern, I guess, is twofold. I think we'll have to wait and see what the Supreme Court says about whether or not mandating the purchase of health care is constitutional. And second, I still am very concerned that when you look at the sheer numbers, that we don't have sufficient healthcare providers and resources for all those that need healthcare. So I think part of it, how do we get there for the sheer number that will need to have the services? Because right now, has been mentioned, they just don't access, even though they need to, or they access when sometimes it's too late.
Any more questions or things that you'd like responses to? Anybody in the audience been thinking about how you might want to get involved in affecting the system? I asked a doctor in some of my research to prepare for this panel what he would suggest, and he said ask your healthcare provider what they do. This was specifically, he was really focused on the issue of physicians not taking new patients if they were on Medicaid or sometimes Medicare. And he said, just, very politely check in with them and just say that you really support that work that they do. That was his suggestion. He didn't mention whether your office visit would go up $20 the next time if you voice support. But anybody have thoughts about ways they'd like to try to influence the access to health care, change the system, be part of some movement?
Currently, we work on a fee basis, fee per procedure, rather than a total health outcome procedure. So I think it would be better if we were looking at health outcomes rather than how many procedures can be charged and coded to be charged.
Is it an effect change like that? Is there anything, somebody like me, like outside the healthcare system can do Is it all call your legislators? Is it write letters? What is it? What are things people can do? All of these 7 panelists thought of this beforehand, so I'm sure they have 10-second answers. Who wants to go first?
I was just going to say, actually, in the CCO model, that's the change is to look at outcomes and provide incentives for outcomes. So that's the direction that